Welcome to the Explainer. Look, if you're gearing up for boards or hitting the wards, you already know we don't have time for fluff. So today, we're doing a high-yield boot camp strictly focused on Yersinia testing, clinical diagnosis, and treatments. We're going to get you the pure, unfiltered facts to absolutely crush your exams. You know, we tend to think of the plague as just like medieval history with those creepy bird masks, right? But this pathogen is absolutely still lurking in modern clinical vignettes and real-world ERs. So let's just get right into it.
Okay, here's our game plan. First up, a quick overview of the Yersinia family. Second, we're diagnosing the plague. Third, we'll hit the treatment protocols for Y. pestis. Fourth, we'll check out its tricky cousins, enterocolytica and pseudotuberculosis. And finally, we'll wrap the whole thing up with those absolute must-know, high-yield clinical warnings.
All right, part 1, the Yersinia family overview. So why are we even talking about this today? Well, 98%. That is the staggering, untreated mortality rate for primary pneumonic plague. I mean, think about that number for a second. This happens when infectious droplets are inhaled directly, usually person to person, and literally within hours, or maybe a couple of days, the patient develops a violent cough, hemoptysis, and just extreme dyspnea. That terrifyingly rapid clinical deterioration is exactly why mastering this pathogen's profile is so critical for us.
Now, this brilliantly illustrates one of the most classic, highly testable board traps you're ever going to see: temperature and motility. The big bad of the group, Yersinia pestis, is totally non-motile at both 37 degrees and 25 degrees Celsius. But contrast that with its cousins, enterocolytica and pseudotuberculosis. They are motile, but only at 25 degrees. Why does that matter? Well, 25 degrees mimics the cooler ambient temp inside the flea vector, so the bacteria actually become motile to survive and spread. But 37 degrees? That mimics a warm human host, where they don't really need motility anymore. Seriously, lock that temperature difference into your brain right now.
Moving on to Section 2, diagnosing the plague.
So the defining feature of the bubonic form, which, by the way, makes up about 82% of cases in the U.S., is the bubo. Picture a patient walking into your ER. They've got a sudden onset fever, and you find this swollen lymph node that is exquisitely tender to the touch. It's boggy, it's got striking erythema over it. That suddenly appearing node right at the inoculation site, that's your bubo. And usually this comes from the bite of the oriental rat flea. Remember, the location of the flea bite dictates the bubo's location. So an inguinal bite equals an inguinal bubo, an axillary bite equals an axillary bubo.
Okay, when you run a Wason or Reit-Gimsa stain, you are hunting for bipolar staining. The absolute, undeniable buzzword you have to know is the closed safety pin appearance. Why safety pin? Basically, the specific stains concentrate super densely at the opposing poles of the bacillus, leaving the center looking kind of clear. If you see this bipolar shape in a direct blood smear from a patient who didn't have a prior bubo, you are dealing with primary septicemic plague. And guys, that means massive bacteremia, shock, and a highly guarded prognosis.
So how do we build out our diagnostic timeline? Step 1, aspirate the bubo. Step 2, perform that Gram or Risen stain and get a culture going. Step 3, draw blood cultures, especially if you're suspecting the septicemic or pneumonic forms. And Step 4, use the F1 rapid diagnostic test, or F1 RDT. This is a strip that targets the F1 antigen, which is the capsule-forming protein. And this is so crucial because, frankly, waiting days for a culture in resource-limited or endemic regions like Madagascar or the DRC, that can literally be a death sentence. That rapid test is a total game changer for immediate intervention on the ground.
Section 3, Y. pestis treatment protocols.
All right, let's break down our antibiotic arsenal. Streptomycin used to be the gold standard, but it carries some pretty severe vestibular and renal toxicity risks, plus it can be hard to get these days. Because of that, the crucial point here is that gentamicin is now the preferred modern systemic therapy. It's way more available and has a much better safety profile. Doxycycline is a great oral option for uncomplicated bubonic cases. Fluoroquinolones? Those are FDA approved for all forms, even bioterrorism scenarios. And don't forget chloramphenicol. You're reserving that specifically for CNS complications like meningitis because it penetrates tissue incredibly well.
All right, Section 4. Let's talk about the tricky foodborne cousins, enterocolytica and pseudotuberculosis.
If you're dealing with older children or adult patients, you have got to watch out for pseudoappendicitis. This presents a severe right iliac fossa pain caused by terminal ileitis and mesenteric adenitis, and it mimics acute appendicitis perfectly. Seriously, burn this clinical jargon into your brain right now because it is a classic test day trap. Misdiagnosing this leads to unnecessary appendectomacies all the time. Recognizing pseudoappendicitis literally saves your patient from going under the knife for no reason.
Now, what's really interesting here is how you cleanly tell these two apart. Imagine a clinical vignette where a patient recently prepared chitterlings, raw pork intestines. That strong raw pork link? Classic setup for Yersinia enterocolitica. On the flip side, if the patient was exposed to wild game or birds, you're going to lean toward pseudotuberculosis. Both are oral transmission, both can cause reactive arthritis in HLA-B27 positive patients, but enterocolitica can also trigger erythema nodosum, especially in young women, which isn't linked to HLA-B27.
Okay, here's a rapid-fire pearl for your exams. Yersinia enterocolitica is psychrotrophic. That means it loves the cold, and it actively grows at 4 degrees Celsius. Think about what that actually means. While red blood cells are just chilling in the fridge for weeks, this bacteria is actively multiplying. Because of this, it can heavily contaminate refrigerated blood products stored for more than 20 days, and that can cause massive, potentially fatal transfusion-associated sepsis the exact second that blood hits your patient's veins.
Finally, Section 5, the absolute do-nots and high-yield clinical warnings.
I want to pause here and pose a crucial question right to you. What happens if an iron-overloaded patient, say someone with hemochromatosis or diabetes, gets a Yersinia infection? Take a second. Think deeply about their active medications and what might actually interact with the bacteria.
Got it? The answer is a totally counterintuitive mechanism that test makers love. The iron chelator desferrioxamine actually increases the risk of Yersinia sepsis. Crazy, right? Well, it acts as a cytophore for the bacteria. It's basically serving up iron on a silver platter directly to the pathogen in a form it can easily use. So instead of protecting the patient, the medication is just fueling rapid bacterial replication and severe sepsis. All right, let's lock in these life-saving rules. I'm putting on my clinical coach hat here. First, do not remove the appendix for yersiniosis-causing pseudoappendicitis. Second, for pneumonic plague, you absolutely must initiate droplet precautions until the patient has had 48 hours of effective antibiotics. And third, never give beta-lactams alone for systemic enterocolitica infections. Because it's an intrinsic beta-lactamase producer, throwing a standard penicillin derivative like ampicillin or amoxicillin at it will just fail and your patient's going to tank.
So are you ready to spot that closed safety pin and save your next patient? You've got the framework now. You understand the tricky mechanisms. You know the board traps. Review this explainer, internalize these facts, and you're going to have that diagnostic edge you need to completely crush those vignettes and thrive on the wards. Keep that focus sharp, and we'll see you next time.